Welcome to today's episode of the Medical Fitness Podcast, powered by the Medical Fitness Association and MRF Institute. My name is Thomas Hammett. I'm the Director of Operations for Pinnacle Lifestyle Medicine and the co-founder of the Medicine Rehab and Fitness Institute. Today, I'm excited to have Dr. Robert Newton with me on the podcast. Dr. Newton is a Vice Chancellor's Professorial Research Fellow and Professor of Exercise Medicine at the Exercise Medicine Research Institute, which he founded in 2003 at Edith Cowan University in Perth, Australia. He's an accredited exercise physiologist and has received several distinctions from the NSCA and ACSM, including being recognized as fellow for both organizations. In 2019, Dr. Newton was named Western Australia's Premier Scientist of the Year. He's published over 1,150 scientific papers and has been cited over 33,000 times. His topic of greatest publication output is on the topics of exercise and cancer, which we'll talk mostly about today. This is honestly just scratching the surface in terms of Dr. Newton's CV. He's an incredible guest to have on the podcast. Dr. Newton, I'm excited you're here. And just as a side note, this is the first podcast that we're doing where the guest is on a different day of the week than the host. I'm here on Thursday, January 16th at 5 p.m. and you're ahead of me 16 hours on Friday in Western Australia. So I'm really excited to have you join us. And thanks for being here.
Oh, thanks, Thomas. Absolute pleasure. Yeah, it's Friday morning at 9 o'clock. And I'm bright-eyed and bushy-tailed. I've been to the gym this morning and done a hard workout, or relative for me. And deadlifts, lots of deadlifts. So I'm all ready to go. So I hope I can give you some insight into the field of exercise oncology.
That's great. I did deadlifts this morning too. It was actually 12 hours ago though, so different story, a little less recent for me. So I'd love it if you wouldn't mind. I shared a little bit of your background, but I'd love for you to just give me an introduction in terms of anything else that you would want to share, and maybe even starting with how you got into the field of exercise as well.
Oh, certainly. So I started in the field of exercise sports science in well over 40 years ago. Now, it was 1980. So I guess many of your audience members weren't born at that time. But I was pursuing really high performance, and it was in the sport tactical areas, and that was my interest. I was doing a lot in physiology of strength and muscle size, muscle mass, but it was all around a very, I guess, application in terms of just the basic human physiology, and that's what I was interested in. I was very fortunate to do my postdoc at Penn State University, and under Professor William Kramer, who's an absolute legend in the field of strength and conditioning. And we still work together today, actually, some 30-something years later. But, it was that experience of working at the highest level of sport. I was very fortunate when I was in the US. I got the opportunity to work with a number of exceptional athletes, certainly the athletes at Penn State. I was doing a lot of work with the volleyball team, basketball there. I mean, these are outstanding, obviously, Division I athletes. Many were in the Olympic Games, or went on to Olympic Games, or went on to NBA, etc. And also at that time, I had the opportunity. I was invited to do some consultancy work with the Chicago Bulls, and with world-renowned strength and conditioning coach there, Mr. Al Vermeil, who I've gained absolute legend in the field of strength and conditioning. And Al asked me to come up because of my work I was doing around muscular power and how muscular power is actually produced and how it's expressed and then how it's actually developed and trained. And the reason for that at the time was there was this huge emphasis on strength. It was in collegiate sport and also in the pros. It was, just get them as strong as you possibly can, and everything else will fall into place. That's important, but it's not the actual, the whole basis of it. It's just one component. And my PhD was in the development of neuromuscular power and the underlying physiology and morphology of that. So that's why Al asked me to go up to Deerfield to the training facility there, and it was an incredible time, glorious time in the early 90s when Chicago Bulls were obviously going through their incredible run of NBA titles, and the athletes that were there. Quickly, a few other opportunities there with New Jersey Nets, Miami Heat, a couple of other teams there, and then I started at that time to become more interested in muscular power expression in older people, because I was seeing that this was a major issue, and a lot of the health recommendations at that time, certainly the ACSM recommendations, was to do aerobic exercise, and there was very little emphasis on strength and power. And observing how we age and the problems that we face as aging around frailty and declines in function, it was clear to me that we needed a much greater emphasis on muscle size, strength and power of the neuromuscular system. And so as part of my postdoc there at Penn State, I launched a study looking at power development in old men. And I actually had old men jumping with weights, and it was just amazing to observe the incredible improvements that they had in their physical function, and just because they were doing explosive type activities, and stepping away from the recommendations at the time from American College of Sports Medicine of just get out and walk, and walk as much as you can, and that. And that sort of led me to get really interested in that, and I started to. I continued my work in high performance sport, but I really started to move towards let's look at these health outcomes, and particularly as we age. And I then got an opportunity to go to Ball State University. I was hired as the director of the biomechanics laboratory at Ball State University in Muncie, Indiana, and that was adjunct or next door to the Human Performance Center. So the HPC at Ball State's, again, world renowned. It's one of the top human performance centers in the planet, and originally put together by David Costel. Professor Costel built that up and really drove the field of human performance. And it was there that I was working again with older folk. Obviously, I was actually running the biomechanics laboratory, and we were doing research again, still in athletes and high performance, and particularly neuromuscular power. But I was then actually associated with a very good program they had there, which was a program to bring older members of the community onto campus and have them doing physical exercise, and physical exercise primarily to maintain or improve their health. And I got very interested in that. Now, subsequently, after 3 years at Ball State, I was approached by Edith Cowan University in Perth, Western Australia, and they offered me a professorial chair, which in exercise sports science is very rare. At the time, there was only a few in Australia. So I was fortunate to be successful and picked up a position to move back to Australia with my family, took my family back. And my pitch, if you like, to Edith Cowan University, or ECU as we call it, was to actually develop a strong research program and clinical program in exercise medicine, and to expand our understanding of how exercise is truly a medicine. And a few years before that, my father passed away actually from prostate cancer, and he received a prostatectomy. He went for radiation therapy for about 6 weeks, and he came back from that, returned home, and was just absolutely decimated. He lost a lot of muscle mass, a lot of weight. He was weak, overwhelming fatigue associated with the treatments. And the advice that he was given was to rest. Now, we're talking some 28 years ago, and that was the understanding then of how do you manage a person with cancer, is they have to rest, they have to recover. And so I saw my father and I saw his decline, and I said, "Come on, Dad, let's go for a walk." And he said, "Oh, no, I'm just so tired. Would you do some weights? Let's do some, because I see your muscles are disappearing, you're wasting away." No, the doctor told me to rest. And every fibre of my being told me that this was wrong. my understanding of physiology, and I spent a lot of years studying physiology, told me that this rest strategy was false and that it needed to change. And so I tried to get my dad up to move, but of course the clinician, the urologist in this case, was his primary physician, and it was just, my dad, I'd take him to the doctor, and we'd explain, look, he's just got this overwhelming fatigue, he's wasting away, and the doctor said, well, you have to get over this, you have to get over the disease, you have to get over the radiation therapy, you have to rest to let your body recover. Well, 2 years later, he died of a stroke. And that's what we now know, is that many patients will actually die of a different chronic disease. They won't die of their cancer. Predominantly, they'll die of cardiovascular disease, heart attack or stroke. And in part because of the treatments, but also that, they're adopting this rest strategy, and all of the other chronic diseases accelerate. Your physiology does not care that you've got cancer. If you adopt a sedentary lifestyle, or you continue your sedentary lifestyle, if you don't adjust your dietary intake to be more healthy, then all of the other chronic diseases will take off. Cardiovascular disease, metabolic disease, etc. And so that led me, I'm highly motivated then to pursue exercise medicine for people with cancer as a cancer management treatment. And a field we now know to be called, which has been coined over the last 5 to 7 years, as exercise oncology as a field. And so for the past 22 years now, at ECU, my team and I have been investigating the use of exercise as a medicine in the management of people with cancer. Wide range of cancers, from prostate to mesothelioma, lung cancer, etc. But the overwhelming theme is, how do we apply exercise to improve the outcomes for people going through a cancer experience? So that's a very long-winded explanation of the background and how we get to where we are.
It's great. Well, I really appreciate you sharing all the way back to the days at Penn State. Yeah, it's interesting. We just had a few months ago, Dr. Kramer was on for a 2-part podcast with us.
Oh, fantastic.
So one of the co-hosts of this show was actually at Penn State in the 90s, and did some research with Dr. Kramer as well. And for purposes of going on the medical route with this and focusing on exercise oncology, we probably won't get to talk much about those days, but I'm really glad you brought it up. I think it's cool how often those we pass common thread kind of thing. So, but you started to talk about exercise oncology, and this is really where I think we'll end up focusing much of our conversation today moving forward.
Sure.
You've started to define it, and one of the things that one of my favorite things that you talk about with exercise oncology is about how exercise creates a cancer-suppressive environment. Do you mind just telling me a little bit more about what that means, and even go into some of the cancer-suppressing mechanisms that exercise has?
Certainly, and this is, I think, where it's particularly exciting, the field. It's obvious that if you exercise, you have better outcomes. You survive better. If nothing else, your quality of life is better if you exercise. But to really get exercise oncology embedded within cancer care, we need to demonstrate the mechanistic underpinnings of how exercise actually suppresses the growth of the cancer cells, the development of the tumour. I published a paper where we proposed 10 mechanisms by which exercise actually alters tumour biology and changes the systemic environment, the microenvironment within the tumour to be more cancer suppressive. It makes the cancer cells, it makes it more difficult for them to survive. There's probably 12 plus mechanisms now. There's been a couple added to that. I won't go into all of them, probably discuss the ones which we're particularly interested in and we're investigating at the moment. So our traditional understanding of the skeletal muscle system is that it's responsible for movement, and also obviously for keeping us warm through shivering and those mechanisms. But around 10 years ago, it was proposed that the skeletal muscle system, the tissue, is in fact the largest endocrine organ in the body in a normal weight individual. We now know that our skeletal muscles pour out a whole range of hormones and other signaling molecules called cytokines. Now, when they're released from muscle, they're actually termed myokines, hence, derived from muscle. And it's these myokines which affect every single tissue in the body. They signal to everything. And this includes signaling to cancer cells. Now, our research, and we've published several papers over the last few years, where we've been looking at the muscles how they actually produce these myokines and the signaling influences that they have. There's several mechanisms. The first one is that these myokines actually signal directly to tumour cells to alter their behaviour. These myokines can actually drive the cancer cells to die, to actually do programmed cell death or apoptosis. They also signal to cancer cells to reduce their rate of growth, their rate of replication, to sort of settle down, guys. That's signaling there, so causing them to settle and not grow as quickly. And it's those mechanisms which have that direct signaling effect. We also see that the myokines produced from our muscles have a very intimate interaction with our immune system. And certain myokines actually stimulate our innate immune cells, our natural killer cells and our T cells, actually stimulate them to be more effective at infiltrating the tumour, seeking out and identifying cancer cells. And these myokines actually stimulate our natural killer cells to be much more vigilant and effective in locating and destroying cancer cells. And that occurs both in the tumour, but also circulating tumour cells, cancer cells as well. So that sort of mechanism is very, very important. It's something that we're spending a lot of time on. And we've demonstrated in men with prostate cancer, for example, that if you exercise them, these are men with advanced prostate cancer, so it's metastatic. It's actually spread to the bones. It's an advanced disease. It's quite aggressive. And what we've shown is that these men, even though they're older, they've undergone a lot of treatment, they have a very advanced cancer. If we exercise them, in this case over 6 months, we saw that the elevation of these anti-cancer myokines was considerable. So you're actually lifting the level of anti-cancer medicine within the bodies of these men. Now, what we then did was we actually took the blood from these men, these patients, before they started the intervention, and then after 6 months of a fairly intense training program consisting of both resistance training and aerobic training. And then we poured the serum, we extracted the serum from the blood and exposed living prostate cancer cells to that. And what we saw was around a 20% suppression of growth. So this is evidence that over, in this case, 6 months of exercise training, that these patients are changing their internal chemistry such that their blood or the fluids within their body now suppress the rate of growth of these cancer cells quite considerably. We then looked at, this is the longitudinal effect. We looked at, what does an individual exercise bout do? And so again, we took patients with advanced prostate cancer that had been training for 3 months at least, and so they had a bit of a training background, and we had them do a high intensity interval training session of about 30 to 45 minutes. Again, we drew the blood immediately post and then immediately after. And then what we saw was a nice elevation over that training session, that training bout, in these anti-cancer myokines. Again, we took the serum out of the blood and exposed living prostate cancer cells to that. And again, we saw an additional suppression. So what does this tell us? Chronic training, exercise training, induces the body to produce a more cancer-suppressive environment. And every exercise session that you do provides another dose of anti-cancer medicine, endogenous medicine, so medicine produced from within the body. So the third mechanism by which this alters to produce a more cancer-suppressive environment is the interaction with our fat cells, with our adipose tissue. Now, the adipose tissue also produces cytokines called adipokines, and these tend to have a cancer-promoting effect. And of course, high levels of fat in the body also results in an elevated level of systemic inflammation, alteration in our metabolic health, and alteration in our endocrine system, in particularly around the metabolic hormones of insulin and glucagon. Now, high levels of fat tissue produce a more cancer-promoting environment. Now, what we see is that when we exercise, we have these myokines produced, and they tend to cancel out, or they tend to suppress these cancer-promoting molecules being produced by our fat cells. And so that's the third mechanism that we're exploring as well, which seems very, very important for explaining why, in fact, Thomas, that people with cancer who are physically active, they more than double their chances of survival. Now, that's quite striking, because that's getting around the same level we see, with mainstream treatments like chemotherapy or radiation therapy. And the message is definitely not just exercise and forget about your medical treatments. That's not the message at all. And the message is that exercise medicine is an absolutely crucial adjuvant treatment alongside the other mainstream medical treatments of surgery, chemotherapy, radiation therapy, immunotherapy, and hormone therapy.
I have to tell you, Rob, you're making this really easy for me as a host, because you're explaining things so both the complexity and the simplicity with what you're explaining. I think it's clear that there are complex mechanisms that, with both skeletal muscle being present and exercise, creates a hostile environment for cancer cells, right? Like, you've done a really good job explaining how exercise and having skeletal muscle makes it really not a cancer-friendly environment, just by what your body does in response to the activity of exercise and having skeletal muscle. So thank you for making it so easy for me as a host today. You're just getting right into it and making it seem like, honestly, I wish I could put you in front of all of our referring providers and help them understand how simple this exercise, the benefits of exercise can be for the cancer population, how powerful, for that matter. You started to get into both the presence of skeletal muscle and also adipose tissue, and what you seem to have identified is that muscle mass and quality are really important for predicting cancer outcomes. You kind of already talked about how greater muscle mass and quality helps improve cancer outcomes. If there's anything additional that you'd want to add about that, or even, I guess, maybe of what I'd say on the other side, patients with sarcopenia tend to have worse outcomes. And I'd love for you to explain that part a little bit deeper as well, if that's all right.
The Medical Fitness Podcast is brought to you in part by the Medical Fitness Association. Are you a professional in the medical fitness industry? As a member of the Medical Fitness Association, you'll unlock exclusive networking opportunities with top experts in the field. Access cutting-edge education to stay ahead of industry trends and best practices. Don't miss out on the chance to advance your career. Join the Medical Fitness Association today. Visit medicalfitness.org to become a member. That's medicalfitness.org.
Yeah, certainly. And that's a really important question, a really important message to get across to patients and clinicians. Cancer is becoming more difficult to treat. Incidence is going up, and it's occurring at a younger age. One of the main drivers for that is the change in the body composition of the human. We're seeing through lifestyle factors of low levels of physical activity, in particular low levels of lifting heavy things, so low levels of stimulus to the muscle, and also inappropriate diet. And so this is over and over in the media and the scientific literature, but the world is becoming higher in levels of fat in individuals and lower in levels of their muscle. So we talked about the skeletal muscle system as the largest endocrine organ in the body, so endocrine producing hormones and other signaling molecules. But adipose tissue is also an enormous endocrine organ. The problem we have is, as the body composition of the human as a species changes, we've got a yin and a yang, and unfortunately the level of fat, now we see the actual mass of fat is greater than the mass of muscle in the average human, and sometimes it's many times larger. That's a problem because you've got yin and yang is out of balance. You have the very large mass of fat, which is just overwhelming the system in terms of cancer promotion and just driving and feeding the cancer and creating an environment for cancer cells to survive and to do well and proliferate. So the way I like to think about it is that your skeletal muscle system is the pharmacy of your body. So it's producing a whole range of really beneficial medicines. Now, if you have sarcopenia, if you have low muscle mass, then you'll have a tiny little drugstore, which only has a limited number of amount of drugs that it can produce. And so that's why it's so important to build up that drugstore, to make that muscle mass as large as possible, so that we have a large drugstore that can really, really dispense a lot of these anti-cancer medicines for us, and certainly to balance out the other. It's the bad drugstore around the corner, which is producing bad drugs, and to balance that out in terms of the adipose tissue. The interesting thing is that our group has published several papers, but a lot of other groups around the world, and have shown that there's actually, in terms of cancer progression and cancer-specific survival, muscle mass is more prognostic than fat mass. So it appears that having low muscle mass is a greater driver of poor prognosis and death than is having high fat mass. Now, don't get me wrong, we have to have balance. We have to, if the patient is quite high fat mass, we have to address that as well. But if you have to choose, probably you would look really, really to try and build muscle on the patient and address fat mass as a secondary component, simply because the risk of death from having low muscle mass is much higher than the risk associated with having high fat mass.
Yeah, so it's clear that screening for people with low muscle mass would just be so important at the beginning of any kind of cancer treatment. I'm curious how consistently sarcopenia or low muscle mass is screened as part of the pre-treatment or even treatment process with cancer. Do you know?
It's not. It's not considered really. Some patients will receive a CT to actually look at other factors around the cancer, and from that, it can be used to look at muscle cross-sectional area. We use DEXA, which is pretty much ubiquitous now. Those machines are in a lot of different places. And so we use DEXA to actually quantify the mass of muscle and the mass of fat in the body. And certainly we do screen for patients who are low muscle mass or are actually truly sarcopenic. And then we target that with exercise prescription as a priority. We have to turn that around. We have to address that. And in many cases, that may be more important than the aerobic training, for example. We're more concerned about low muscle mass than low cardiorespiratory fitness for those particular patients. I think it should be. I mean, a DEXA scan is very low radiation, it's very low risk, it's relatively inexpensive. I think it's an important tool for determining body composition in patients with cancer.
Yeah, even after the beginning of this call and some of the reading I've done on your work, if I knew someone right now that was at the beginning of a cancer diagnosis, I would insist that they go get some kind of body composition screening to understand their risk level and to think about the exercise that would be involved with their treatment plan. Regardless of the risk, I'd still say there needs to be exercise as part of your treatment plan. But it feels so important to me based on everything that you shared about muscle mass and the way that it affects the environment with cancer treatment.
Sure.
Yeah. I'd love to start talking about what the exercise actually looks like for some of the studies you've done, and even just start with, in a best case world, what does the effective exercise look like for cancer patients?
Sure. Look, Thomas, the bottom line is that most cancer patients will be totally sedentary. I mean, they just reflect the human population. So if you're sedentary and you have cancer, you are really compromising the capacity of your body to beat this thing. You are really compromising the capacity of your medical team to help you survive. There's no doubt about it. So the first thing is get off the couch. You have to move, and even if that movement is limited, if even if it is just walks around the block, or even in some cases patients with quite severe disease, it might be just walking to the front door and back, or something like that. But you have to get off the couch, you have to get out of bed, you have to move. So that's number one. Look, for patients that are relatively well, the American College of Sports Medicine guidelines are pretty well matched those for healthy older adults, which is 75 to 150 minutes per week of moderate to high intensity aerobic training, and then 2 or more resistance training sessions per week. Now, that's fine for particularly younger patients who are doing, who are relatively well. Clearly, for patients that are experiencing considerable effects of the disease, but also the treatments, we have to be a lot sharper. We have to give precision exercise medicine in this case. And what we proposed in 2019 in the Australian guidelines for exercise medicine in cancer management was that the patient needs a thorough health and fitness assessment, including body composition, and then prioritising what is going to cause the greatest morbidity or mortality risk for that patient, and then targeting that laser-like. Forget about everything else. You have to address what is going to cause their greatest risk. And so for someone who has low muscle mass, or even cachexia, which is an uncontrolled loss of body weight, forget about the aerobic exercise. It's not important. We don't do any. We don't prescribe that. We prescribe targeted resistance training with a strong emphasis on known techniques which produce muscle growth. And so these are in our case, quite advanced techniques that we're using there. The techniques that we know work exceptionally well from high performance research. I think it's been very fortunate that I had 20 plus years experience working in high performance, because we know so much about human physiology and training. We know so much about how you build a better human. How do you make a human more resilient to compete at the highest level of sport, or to travel in space, or to be a tactical warfighter? We know a lot about how to do that. So it is about taking that and then applying it in the clinical space. So, we've got to move away from 3 sets of 10 reps. We have to be a lot more sophisticated. These are people with high potential that they're going to die. And so we have to, it is on us as clinicians to provide the optimal treatment. And, I take the case of chemotherapy. If you were to say to a patient, look, it's unfortunate, but, you have, let's choose something, you have advanced cancer of the pancreas. And this is my recommended treatments. This is the latest. This is the clinical trials. What they demonstrate will give you the best chance of living as long as you can. But in exercise, what we're doing is we're giving them either no treatment, we're not offering them anything, or we're giving them light exercise. Oh, you've got cancer of the pancreas. That's really tough. That's a hard cancer. Look, just do what you can, and maybe go for nice gentle walks and things like that. That might help their mental health, but it's not going to change the trajectory of their cancer. And so it's going to have to be a targeted program, which is really going to have to emphasize on trying to suppress the cancer as much as possible. And also, one of the key purposes of exercise oncology is to control the adverse effects of treatment. So, someone with advanced cancer of the pancreas or receiving quite nasty chemotherapy, that has huge impacts on their health. It controls the cancer, yes, but a whole range of side effects. And we know that specific exercise will help to suppress those side effects. And so we need to move to this precision exercise medicine model, whereby we are really targeting what is going to cause the greatest risk of mortality and morbidity for the patient. Now, coming back around then to my example of a patient who has low muscle mass, they've got advanced cancer, they've received a lot of treatments, they've been in hospital in and out and sedentary, so they've lost a lot of muscle mass. In that case, the program is highly targeted. We use obviously resistance training, we use accentuated eccentric training, we try and stimulate their endocrine system to produce as anabolic environment as we possibly can. So again, we draw on a lot of Dr. Kramer's work that he's done around it, and a whole range of others, as to how you manipulate the underlying exercise parameters to produce the most anabolic environment we can. We remove any aerobic exercise. Going for gentle walks is only going to make the muscle loss worse. because you've got strong catabolic drivers here within the body due to the cancer and its treatment, which are causing muscle loss of protein. The last thing you want to do is make that worse by having them do a whole lot of aerobic exercise. Even if it's gentle exercise, you need to avoid that. So in the exercise that they do, it needs to be focused, it needs to be moderate to high intensity, and it needs to be exceptionally high quality to try and maintain or even to grow as much muscle mass as we can. Now, I have many colleagues that say, well, the exercise needs to be fun. I'm sorry, Thomas, but chemotherapy is not fun. Unfortunately, I've never had to have it, but I've seen hundreds of patients that have. It's not fun. And in that case, if this makes the difference between whether the patient can stay functional for another month or 2 months or another year, or perhaps they can add some months or years to their survival, then the exercise may not be fun. They may be in the exercise clinic doing high intensity resistance training, including accentuated eccentric training, the whole gamut of other methodologies we know that stimulate muscle growth. Blood flow restriction, for example, is receiving a lot of attention now in patients with cancer. We do a lot around manipulation of their diet. We look at nutrient timing. We look at supplementation with amino acids and protein in general around that. We're working to do everything we possibly can, in this case, with a patient that has low muscle mass or is suffering from cachexia, everything we possibly can to try and reverse that or slow the decline at best as well. So definitely we need to move to a precision exercise oncology model.
Yeah, well, and you call it exercise medicine for a reason, right? It's not called exercise entertainment. We use a term here in the Northwest at our clinics that we're not providing exertainment, that this is exercise intended for a specific outcome and delivered in a way that's meant to give you the results you're looking for. And I really appreciate how unapologetic you are about, like, yeah, this may not be fun. And if you want to get the kind of exercise that's going to contribute to a greater chance of living longer, which is really what everybody going through this wants, right? Nobody really wants to spend their free time doing something that they don't have to do. And in this case, if this is extending your life, it is, I think for most people, it's something that should be offered and is worth it, right? So I think it's really incredible how you describe that. And I'm curious how you got to the eccentric work that you're doing. I'd actually love to even just hear like how you're doing that, and what led you down that road of thinking about these alternative methods of resistance training, particularly that one, with this population that I imagine others are probably really careful with and not trying to be very push it.
Certainly. The initial driver for us exploring eccentric exercise was our work with men with prostate cancer. So we've done a lot of work, men with prostate cancer that are on androgen deprivation therapy. So effectively, these men are chemically castrated so that their production of testosterone is blocked, but also the uptake by cells within the body is also blocked. They have no access to testosterone. Now that's a problem because testosterone is clearly a very powerful anabolic hormone. However, there are other mechanisms by which we can produce an anabolism, so hypertrophy within muscles. And one of those models relies on a pathway which is particularly stimulated through eccentric exercise. The other advantage to eccentric exercise is that it doesn't require as much energy, and so we can overload the system in terms of force applied through an eccentric phase, but it's not going to require a large amount of energy and potentially make the patient more tired and exacerbate their fatigue. So that's the drivers for why we've looked at that. We implemented in our exercise clinic through a whole range of ways, which again we just borrow on the traditional high performance training, strength and conditioning, really the strength and conditioning profession. And so, for example, we'll have the exercise physiologist in our case. In Australia, we have an allied health professional called a clinical exercise physiologist. And that's the main allied health professional in Australia that delivers exercise medicine for people with chronic disease, including cancer. And so the exercise physiologist will, for example, if the patient's doing a leg press, then the exercise physiologist will give them some assistance to lift the sled up and then release it, and the patient will do a controlled lower. A whole range you don't need that sort of equipment. You don't need an exercise physiologist to help you as well. Just actually accentuating the eccentric by just slowing it down. So, for example, if we do a lot of work where the patients are exercising at home, we do use telehealth extensively, and we deliver the exercise program to them through their smartphones. And what we'll do is we'll just have phase timing. So if we program and say, okay, you're going to do some body weight squats, then I'll get you to actually stand up in a 1 or 2 second count, but then I want you to lower back down to a 4 second count. So that's longer time that they're under that eccentric phase. So there's ways you can do accentuated eccentric from the basic no equipment required right through to considerable supervision and assistance. And we use the Technogym BioStrength system extensively, and that allows us to actually program in for the patient an accentuated eccentric. So they can do a leg press again, we'll choose that. They can actually press out with, say, 100 kilos, 220 count, but then because it's basically a robot, the machine will actually push down with an additional 30% or 50% of load. So they have to lower 130. And again, we're using that extensively with the Technogym BioStrength system.
Yeah, we're actually using the same system that you were just talking about with BioStrength in the cardiac rehab population. I shared with you before we were on the call, I'm sitting in a cardiac rehab department right now as we're talking, and just across this window next to me here is sitting our BioStrength equipment, and we're using that eccentric overload with the cardiac population. So definitely a lot of application, and I think the benefit to that is that in the medical application, safety, right? Just the ability to do something like that and be able to count on the equipment to do it safely is really nice for us. I want to go back to something you said, though, mostly because this isn't my area of expertise, and I think it's really interesting, and I want to make sure I understand it, that for people going through prostate cancer treatment, some of whom are, as you said, chemically castrated or have low to no testosterone, this eccentric training, what does that do for them from a muscle mass perspective? Is this helping them maintain? Are they able to hypertrophy at some level? And what would be typical
Absolutely.
for people not doing that?
Oh, absolutely. Look, it's interesting that even in the absence of testosterone, these patients retain the capacity for muscle growth. That's undoubted. And one of our very early studies that we did almost 2 decades ago, and these were men that were on androgen deprivation therapy, chemically castrated. And what we showed was around an 800 gram increase in muscle mass in 3 months. Now, these were old men. Mean age was not that old. I'm 63. So the mean age was 67 for these men. And they were still able to, on average, increase their muscle mass by about 800 grams. Some of the men put on 3 kilograms of lean tissue over that 3-month intervention. So they still retain this capacity. Having said that, some of the men continued to lose muscle mass, even though they were doing the same resistance training program. So take-home message from that is there is quite heterogeneity between different patients, and we've got to be cognizant of that. What we did see in that particular study, we also monitored growth hormone, and we saw some really nice increases in growth hormone. Now, growth hormone, again, is a very, very powerful anabolic for a whole range of tissues, including muscle. And so we proposed that this growth hormone was probably the predominant anabolic mechanism which was supporting this. At the end of the day, who cares what it was? We produced some good muscle growth. And that was the first study ever to show that we could actually increase muscle mass in these men with a very targeted resistance training program. And this wasn't playing with fluffy balls or 2-kilo dumbbells. This was guys doing heavy lifting, relative. Okay, so we've had them doing sets of between 6 and 12 RM. So their relative weight is relatively high. Okay, we always keep 1 to 2 reps in reserve, and so There's no point in these patients to push them until they're absolute neuromuscular failure. There's no additional benefit. Now, yes, we do that with athletes, absolutely. We take them right until the point of failure, and we take them beyond that. We say, okay, we do another couple of assisted reps beyond that because they will get additional neuromuscular benefit from it. But with patients, that's not necessary. We do between 6 and 12 RM sets for our resistance training. In the main, we vary around that. And we have them have 1 to 2 reps in reserve. And that's why we're seeing, some quite good muscle growth through mechanisms other than the testosterone pathway.
Yeah. So, when I drive around in the car and I'm listening to the radio, there's ads on the radio for, if you don't have any energy and you're a man, it's because your testosterone's low and you probably can't get out of bed and so on and so forth. And I feel like the whole narrative around having low testosterone is just even a part of aging, is that it's going to leach your body of muscle. And I just think that's a really incredible result to have seen from the research, and a really great application of, again, something that I think it sounds like you learned from the sport athlete population and performance, and applying it to this population that needs that same kind of modality, but just targeted to their individual needs.
Yeah, absolutely. Probably, I would like to address this low testosterone. If you have a look at the research, testosterone doesn't decline much in men as they age. We don't go through an andropause as such. Look, it does decline somewhat when we get very, very old, but men have the capacity to maintain, normal levels of testosterone well into their 70s and 80s. The reason why the testosterone is declining, what we're receiving in the population, it's not a basic outcome of aging and physiology. It's an outcome of lifestyle. We're not doing heavy lifting. We're not maintaining our muscle mass. And we're, again, 67% of the Australian population is overweight or obese. And so it's our lifestyle which is creating a hormonal imbalance. It's not aging per se. And so sticking a little bit of testosterone into these patients is not nearly as effective as they're actually going down to the exercise clinic or the fitness centre and lifting some really heavy things. That would be a much better benefit for them. A lot cheaper too.
Yes, a lot cheaper. Yeah, that's right. I really appreciate you clarifying that point too. I do think that that's a false narrative. That we talk about this false narrative of health, that you just need to expect that there are milestones as you age that will cause you with pretty much no ability to do anything about it, that aging is just going to take you down. And I really think that we allow that narrative to drive a lot more of our decision making than reality shows, when we know that we're eating a good diet, when, as you pointed out, we're lifting heavy things and doing resistance training and getting our cardiovascular system the exercise it needs and maintaining positive relationships. It does so much to prolong that and not really lead us to this inevitable age is going to be that one thing that determines your quality of life as time goes on. So I'm really glad you mentioned that. The next thing that I wanted to ask you about, maybe just for a few minutes, I'd love to talk about the Interval GAP4 study. This is a study that you've been working on for a while now. For the listener, the full title of the study is Intense Exercise for Survival Among Men with Metastatic Castrate-Resistant Prostate Cancer. Is actually a lot of the work that I think we were just talking about is part of this study. It's sponsored by the Movember Foundation and is part of its Global Action Plan 4, hence the GAP4 part of the name. It's a multi-site randomized control trial that's still ongoing. If you wouldn't mind, could you just tell me a little bit about what led to the creation of the study and just anything that you've learned so far from doing that research?
Sure. So there was a study published, I can't remember the exact year, but it had to be at least 15 years ago, probably longer. It was led by Stacey Penfield at the University of California, San Francisco. And what they reported from epidemiological data was that men who were physically active, and in particular if they were active at a higher intensity of exercise, they had a 61% lower prostate cancer specific death rate. And so you go, wow, that's a big improvement. And You'd think that then exercise programming would be paid for by the government and would be just implemented everywhere, just based on that, because that survival advantage is huge. But it's not. And so the reason why is it's associative, it's not causative. It doesn't demonstrate that the exercise caused the improvement in survival. So I went to Movember. They were funding various global initiatives at that time, and said that we need a definitive randomized control trial to demonstrate that targeted exercise will actually enhance cancer-specific survival. And so they funded that, which was fantastic. The Movember Foundation, I've got to give them full recognition and credit for that. And so that was the genesis of the trial. We looked not only at the actual survival, but also progression-free survival. In other words, does it actually slow the progression of the disease? And also there's a nice actual molecular and cellular component wrapped around that as well. We were also investigating the mechanisms by which the exercise is actually changing the tumour environment, and in how do we actually achieve this improvement in survival. So that's the genesis of it.
That's great. Is there anything that you can tell us? It sounds like this study is being done in multiple places from what I read. So multiple locations running the study. Anything you can tell me about outcomes of the study so far?
Look, we still have another, I think, to the end of this year, until the last patient follow-up, because we follow them up for 2 years after they complete the exercise intervention to look at progression and survival data there. So I can't tell you anything about that as yet. What I can tell you, though, is that the intervention was very well tolerated. We had very high compliance and retention into the study. And these are men with advanced metastatic prostate cancer. The disease is now incurable. You cannot cure the disease at this stage. It's spread to other parts of the body. It's in many cases throughout the skeleton. And so it's very much about trying to extend their survival and extend quality of life. And so the first question is, can men with this level of advanced disease, can they actually exercise? Yes, they can. No problems at all. We've had very, very low levels of adverse events, and any of the adverse events were grade 1 or 2. So that means, relatively minor, things like back strains or a little bit of muscle soreness and that sort of thing. We had absolutely zero high level adverse events. So the first thing to come out is these men can exercise at a very high level of intensity and do it safely under supervision with the correct program. So that was a key thing. Next thing, will they do it? Yeah, they will. You have a look at it. They're turning up to the exercise clinic. They're doing the exercise. This was a program which consisted of heavy resistance training, relatively. We were doing sets of resistance training of 6 to 12 RM, again with 1 or 2 reps in reserve. But they were also doing moderate intensity continuous training and HIIT training, high intensity interval training as well, all very well tolerated. And so I think that's probably the main outcomes at this stage, is that the supervised exercise medicine program for these men with advanced cancer is safe and is well tolerated, and that they will actually do it. And that's important, that they'll actually stay in the program and adhere to the exercise prescription.
Well, I tell you what, I'm going to be waiting until the study gets published to look for the results. I'm really excited to see what you guys end up finding out. Even just the results that you're talking about, it actually coincides with what I've learned recently, which is that a targeted program that's well explained to people, and again, my primary lens of this is in the cardiac rehab population, and if you do things like high intensity interval training, most of the time there's better engagement with HIIT training, even though it's like, I think the impression that I came into it with is that people are going to be scared of pushing it this high into their intensity level after a cardiac event. And the reality is that they have a lot of fun, that moderate intensity continuous training, so getting on a treadmill or a bike and going at the same speed the whole time, is not as fun as doing intervals. And people do appreciate that. Although, again, the goal is not entertainment here. But there is a level of engagement that comes from feeling like you're doing the hard work. And that's something I've certainly learned with prescription. And it sounds like you guys are really pushing these people in the study to do really effective exercise.
Look, I think that the key issue with these patients is that they're very short on time. And, a patient going through cancer has so many other things going on. The majority will still be working. They have family. They might be caring for elderly parents. They've got appointments that they have to go to. They're time poor. And so, being able to give them their dose of exercise in the most efficiently and effective way is very important. And so that's why relatively high intensity, you can get a lot of medicine into them quickly. The other thing is we know from basic physiology, exercise physiology, we know that you have to exercise at a moderate to high intensity to produce this internal medicine. And if you're sticking below the threshold, you're not going to actually be driving that medicine effectively. You have to create such a disturbance to their homeostasis that their endocrine system responds and pours out wonderful hormones, pain suppression. We know that if we exercise at a high level, we pour out these hormones, including hormones from the muscles, which are highly suppressive of pain. They suppress fatigue. And also the immune system. We have to work at a certain intensity to get our immune system to go, hey, we've got to fix this up. We've got to get out there and repair and make this body better, because this guy's going to ask us to do this again next week. And that's just basic, the physiology drivers behind this. So, for someone with cancer, the light intensity's out. The low intensity dancing. Now, don't get me wrong. They can do that. They can still, go to their dance classes or go walking the Labrador around the block. That's fine. That's different. That should be fun, and that's physical activity. But this is exercise medicine to help this patient survive. And so that's why that intensity paradigm around prescription is just so important.
Yeah, that's great. I'm really glad you mentioned those points, Rob. So I want to maybe ask you one more question as we wrap up here that summarizes kind of, I guess it doesn't summarize everything, but it takes us to a concluding point, which really to me is, with everything that you've said, I am so convinced that exercise needs to be part of the cancer pathway that I'm amazed with what you know from evidence so far, the research you've done, that this isn't the norm at every cancer center in every place in the world. And with such powerful research conclusions on the effectiveness of exercise, do you have any thoughts on why implementation of exercise medicine in cancer pathways is not yet the norm, and what is it going to take to get there?
I think these survival studies will be very, very important. We have the Movember-funded Interval GAP4 study in prostate cancer. There's also the challenge study led by Professor Kerry Cornier out of Canada, and that is in colon cancer. Again, the main focus of that study is survival. I think that once we show a cause effect of enhanced survival through targeted exercise medicine, patients will demand it. Obviously you would, if you look at it and go, wow, this will double my chances of survive. I want this thing. I want this exercise medicine. Also, clinicians will demand it as well. They'll say to their hospital administrator, look, we need this for our patients. It's going to make us look good because our patients are going to do better. And so it'll be that emphasis. And then, of course, it is the lobbying of government. The issue is that exercise oncology is not supported at all in our health systems through Medicaid, Medicare, whatever, wherever it is, what country. And that's a problem. And whilst in Australia we pour enormous amounts of resources into supporting pharmaceutical treatments, we provide little to no money to support exercise medicine, or dietetics for that matter, or psychological support either, which are also exceptionally important in getting the patient through their experience and producing the greatest outcomes for them. And that's a problem. So it will require that lobbying by patients in particular. I think patients are obviously a very, very powerful voice in this. I've seen my patients coming through and, coming to the exercise clinic, and many of them say, cancer diagnosis was the best thing that happened to me. I've turned my life around. I'm the fittest I've been since I was 20 because I've engaged in this exercise medicine. We need to harness that. We need to get those patients out, going to government, going to their local politician and saying, hey, why isn't the taxpayer paying for this? At the end of the day, Thomas, the health economics of it is enormously convincing, because if we can improve the outcomes for the patient in terms of less attendance at emergency, less surgical procedures, less requirement for chemo, radiation therapy. Cancer, particularly towards the end, is exceptionally expensive. And look, it's money which has to be spent to help these people. But if we can delay that or prevent that, the savings to our health system is enormous. It's in the billions. But once again, we need to be able to convince the politicians of this to actually recognise exercise as a medicine, and exercise oncology is a critical component of the care of people with cancer.
Yeah, you hit the nail on the head in terms of the situation here in the United States that, outside of cardiac rehabilitation, there are very few payment mechanisms, certainly like the fee for service, where we bill a code and we get money right back from the insurance company for it. It really doesn't exist for exercise services outside of cardiac rehab. And, with the overwhelming evidence you've shared here today and the work that you continue to do, I just have to say thank you for being a part of that lobbying effort. And, you have at least influenced one program. I mentioned to you before we hopped on this call that I had left a cancer center ribbon cutting ceremony. So here at Valley Medical Center, we're opening a brand new big cancer center that is really just one building away from our fitness center. And we're going to be implementing a lot of the work, a lot of the process that you have published. So you've influenced one department. We're going to do something here the best that we can to apply what we've learned from you in the United States. And I have no doubt that in a short time, what you're talking about will be just the standard of practice throughout the world. But thanks for joining me and sharing so much about what you're doing to get us there. One additional question, just as we wrap up, is there anything in terms of where our listeners can learn more about you that you'd be willing to share, like Twitter or whatever the best way to connect with you is?
I'm sure, Thomas. I mean, I try to be active. I get paid by ECU, and my main role is a researcher. So I get paid to do research, write papers, and apply for grants. That's my main role. But I try to be active on social media. So on Twitter, it's Prof. Rob Newton, and the same for LinkedIn. I'm pretty active on that. And also my Instagram as well. I try to post to that as regularly as well, particularly when new papers come out or new findings from our research or new clinical findings that we have, the way we do things. So it's Prof. Rob Newton, and that's my handle for all of my social media. So that's probably a good opportunity. Madly working on a book at the moment, Exercise Medicine. It's titled My Exercise Medicine for Cancer. And really in that it's a book for the patient and the carer. It's not a clinical book. It's not aimed at clinicians or allied health. It's really aimed at patients. So working on that book at the moment, and people can get details of that on my website, which is myexercisemedicine.com.
It's great. Yeah. So myexercisemedicine.com. You're working on a book. You got a bunch of research going. I really appreciate you spending some time with me today as part of your morning out there on Friday morning. But really, truly, again, thanks so much for sharing everything that you've shared with me today about the work that you're doing in exercise oncology and beyond. Really appreciate your time.
Absolute pleasure, Thomas. Thank you so much for the opportunity. I hope that this will influence some clinicians to recommend exercise medicine to their patients strongly, and also for patients to really embrace and actually demand exercise medicine and to help them through their cancer journey. Thank you so much.
Yeah, that's right. You heard him, everybody. It's a call to action for you. It's time to get going. So, all right. Thanks, Rob.
Good on you. Thanks, Thomas.
This episode of the Medical Fitness Podcast is brought to you by the Medicine, Rehab, and Fitness Institute. The MRFI has been co-founded by medical, rehab, and fitness practitioners who see the medical necessity in getting people to be more active and fit. There is a sleeping giant of opportunity to building a more active population, an opportunity which lies in a more effective medical referral pathway to exercise programs and professionals equipped to serve that pathway. To learn more about our services and how we're working to make this a reality, visit mrfinstitute.org. That's mrfinstitute.org.